Hi, I'm Catherine Morvina. I am the medical director of our epilepsy center. For those of you that don't know, we're a level 4 epilepsy center in San Francisco at California Pacific Medical Center. And I work very closely with Dr. McDougall, who just spoke, um, and then Dr. Laxer, Dr. Wu, Dr. Summers, who couldn't be here because her son was turning 2 this morning or today, and Dr. McMullen, our neuropsychologist. So thanks for being here. My talk is going to be about medications for treating epilepsy. And I'm going to focus mostly on the newer medicines in this treatment or in this talk, but we'll talk about just a broad overview of what treatments are available. So these are my disclosures, and the ones that are relevant to this talk is I am a consultant for Neuralis, which is Valtoco, and then SK Life Science, which is Xcopri. So we're lucky in the field of epilepsy that there's over 30 medications available today. 2025. I did not say the year, sorry about that. So the goal for seizure treatment is not to have any seizures. And then also my goal when I'm evaluating patients is to make sure that the medications that they're on are not causing terrible side effects because we want you to be seizure free, but we also want you to be thriving. And we want your medicines to just be kind of like an afterthought. We don't want you to feel completely sedated and sleepy and feeling drunk from the medicines. So that is my goal when I'm seeing patients in clinic is to not have seizures, also not have terrible side effects from the medications. And the good news is our medicines work pretty well. So about 2/3 of patients with epilepsy, their seizures will be well controlled on the medications alone. And the 1/3 that of patients that medicines don't work, we have surgery. So Dr. McDougall just talked to you about surgical options. But majority of patients that have seizures, the medicines are going to work. So that's the good news. And as we talked about earlier in the presentation, knowing what types of seizures you have can be important for medication selection. So some of our medications that are meant for focal epilepsy can actually worsen seizures in patients with generalized epilepsy. So that's why it's important to know what type of epilepsy you have. And then also, like these with any medications, we do run the risk of side effects. So it's important to me to know what your other medical problems are when I'm taking a medication, because some of the medicines that we have can make conditions like depression worse. Some of the medications we have can actually help treat your other conditions. So if you suffer from migraines, we have medications that can treat both epilepsy and migraines. So that's really important when we're doing a comprehensive evaluation of you and your seizures. Also know about your other medical problems because sometimes we can kill 2 birds with 1 stone. And then it's very, very important to take your medicines regularly. So one of the most common causes of breakthrough seizures is forgetting your medicines. So can't stress how important it is to make sure you have a good routine when you're taking your medicines. And that's also on us too. So some of our medications now, some of the older medicines have now been reformulated to long acting. So it's much easier to remember to take a medicine 1 time a day than twice a day. 3 times a day can be very, very hard to remember. So that is something, even if you feel like the current medicines you're on are working, ask your neurologist if there's an option to change to long acting. I really do like the long acting medications in my patients. And then as always, if you're having side effects, don't just suffer silently. Make sure that you bring that up at every visit. And because it's our job to make sure that you're not having terrible side effects with your medicines. And if you are suffering from seizures and you've been tried on 1 or 2 good doses of anti-seizure medicines, and you're still having seizures, it might be a good time to ask for another opinion from an epilepsy specialist. And our group, we like to partner with outside neurologists to do co-management of seizures, of epilepsy care. And so if you are still having seizures or if you're having bad side effects to your medications, it never hurts to ask for a second opinion. And I say that to my patients too. You know, if we're not getting good seizure control, might be time to get another opinion. So this is a list of medications that are available, and this is broken down by the year or the times that they came out. And so can you see the, oh yeah. So medicines from prior to 1993, these are considered the older medications. And, you know, we still use a lot of these in practice. But what we are finding out is from some of the older medicines, just because we have more experience with them, some of them do have toxicities. For example, phenobarbital, phenytoin, valproate, those are effective medicines, but can cause long-term side effects such as osteoporosis with phenobarbital. That one seems to be one of the worst ones for causing osteoporosis over time. So if you're on these older medicines, it also might be a good idea to ask your neurologist, are there any newer options available? And so since 2012, we've had all of these new medicines coming out. So the next part of the presentation is going to focus on some of the newer therapies, but at the end, I'm happy to answer questions about anything I don't cover. So the first medication that we'll talk about is Briviact, brivaracetam. I'm probably saying that wrong. It's very closely related to Keppra, which is levetiracetam. It was approved in 2016, and one of the main advantages to this medication is it may have less mood side effects than Keppra. So always think is worthwhile if I have a patient who is having side effects to Keppra, but their seizures are well controlled with Keppra, it might be good to trial Briviact and see how it affects the mood. In my experience, it seems to be about 50-50 if it helps. I see some nods from Dr. Laxer. But I think it's worthwhile to try. And the other nice thing about this medicine is you'll notice that the milligrams is lower than what you would get with Keppra. So this medication is more potent than Keppra. So 100 milligrams of Briviact is equal to about 1,000 to 1,500 milligrams of Keppra. So nice to be taking fewer milligrams. There are some drug interactions, so it can make phenytoin levels, which is Silantan, levels higher, and it can make the active metabolite of carbamazepine, it can make that increase. So something to know, if you ever starting a new medicine, make sure your doctor is checking for drug interactions because there are quite a few. The next medication we'll talk about is Epidiolex, which is cannabidiol. This medication has a very interesting history. So this is one of the active ingredients in cannabis. And so what they found, there was this family who blogged about they were giving their child Charlotte's Web, which was a strain of cannabis with a high CBD to THC ratio. So the two active ingredients in cannabis are CBD and THC. THC is what makes you feel that like high, like euphoric feeling. CBD also can kind of like help with like body pain, but it has less psychoactive side effects, so it doesn't make you high. And so, yeah, this family was blogging about this and became advocates for using CBD in their child. And then they did some trials and actually found out that it worked. So it reduced seizures by about 40%. And so that led to Epidiolex, which is purified CBD, being approved in 2018. And the main reason is it does cause decreased activity, electrical activity of the seizure causing, or the neurons that cause seizures. Does have some side effects. I mean, all medicine can have side effects. The main side effect that we worry about is feeling too tired. It can cause some liver issues, especially if you're on Depakote. But I want to stress that it doesn't make people feel high because it doesn't have any THC in it. It's all CBD. The other thing that we look out for is diarrhea, which sometimes can be a good side effect because a lot of our seizure medicines can cause constipation. So this medication can kind of counterbalance the constipating effects of some of the other seizure meds. One thing to know is if you're on Onfi, which is clobazam, it can make those levels increase. We have to be careful about having them together. But oftentimes we do prescribe them together. The next medication that we'll talk about is cenobamate, which is Xcopri. This was approved in 2019. It showed very high efficacy in clinical trials. It works in a novel way. So it works on sodium channels. Lots of the seizure medicines work on sodium channels, but it also works on GABA. And so far, it seems to be very highly effective medications. One of the downsides to it is there are interactions with other seizure medicines. Another downside is it does take a while to titrate up on it. So our target dose is usually around 200. Sometimes we choose to target 100 milligrams. With this medicine, we have to start very small. So we start at 12.5 milligrams and go up every 2 weeks until we reach the target dose. So that is something to know about this medicine. It does take a little bit of time to get on. But our center has very good experience with it. And personally, I've had patients who were about to go for epilepsy surgery. We started them on this medicine, and then their seizures got better controlled. I have a patient who started driving after he started this medicine, and he was someone who was all teed up to go for surgery. So this medication does seem to be one of the stronger ones that we have right now. There are some side effects, though, dizziness, feeling tired, those are the common ones. And then the reason why we start so slow is in the clinical trial, there were some serious allergic reactions. So we titrate it very slowly to get around that. Now we'll talk about Fintepla. So this medication is the newest anti-seizure medicine. It was approved in 2022. And it is approved for seizures that are associated with Dravet and Lennox-Gastaut syndrome, but can be used for other types of epilepsy. What's very interesting about this medication is, so it's fenfluramine, which was one of the, it's a repurposed diet medicine. So in the early 90s, there was a medicine called Fen-Phen, and fenfluramine was one of the medications, as well as phentermine. So this is one part of that medication, and they found out serendipitously that it helped with seizures. And what's also interesting about this medicine is it works in a different way than our other seizure medicines. So it works on the serotonin syndrome, and this medication, because it is a repurposed diet medicine, we do have to watch out for weight loss in this medicine, and it does require some cardiac monitoring as well. Also showed efficacy in clinical trials. The one of the one of the advances in the epilepsy world in the last few years is different ways of taking rescue medicines. So I'm sure some of you have heard about what diastat is. Well, let me back up. Rescue medicines are medicines that you take for seizure emergencies. We have this medicine called diastat, which is normally prescribed in the pediatric population. We don't prescribe it to adults as much because it's a rectal gel to give during breakthrough seizures. And so it didn't really take off that well in the adult population because it's, just hard to give someone a medication rectally during a seizure. And then we switched to giving people pills for seizure rescue. But the problem with taking pills is if you, well, first, you can't really give someone a pill when they're in the middle of having a seizure. The other thing is pills have variable absorption depending on if you just ate some food. The pills for emergency treatment of seizures, they have to get absorbed through the stomach and then go through the liver and then get absorbed into the bloodstream and then travel up to the brain. And so that process could take like anywhere between 15 and 30 minutes. So now we have intranasal medications. And there's two medications that are on the market right now. There's Nasolam and Valtoco. They're approved in 2019 and 2020, respectively. These medications, I think, are a game changer for patients with epilepsy because they get into the system very quickly. So they're nasal as a nasal spray, and it gets absorbed through the nasal mucosa, through the blood vessels, and then those blood vessels communicate directly to the brain. So instead of waiting 30 minutes for the medicines to get in, so these medicines can get into the brain and be effective within like 4 minutes, which is awesome because if you think about, like, let's say you had a seizure right now and we're calling 911, it could take like, up to 30 minutes for the emergency workers to come in and help. So in my practice, I prescribe rescue medicines a lot because it gives patients more control over their seizures. And it's just nice to have that added layer of security. And then, you might not need to call 911 to get treated because these medicines are very similar to the medicines that they would give you IV in the ambulance. So I will close by saying that by how I began, most patients very well controlled on medicines alone, but that still leaves about 30% of our patients, which is about 800,000 people in the United States. Almost 1 million people are still having seizures despite taking their medicines. And so if you still are having seizures despite taking good doses of meds, I think getting an opinion from an epilepsy center would be good for your overall epilepsy care. And that's my talk. I'll take questions now.
We have a question from a Zoom person.
Oh, okay.
Asking if you have an aura, would you use a rescue medicine?
Oh, yeah.
Yeah, and could you repeat the questions?
Yes. So someone on Zoom asked, would you take rescue medicines if you have an aura? And I will say it depends. It really depends. So I have patients that tend to have the same aura prior to having a big seizure. In that case, I would say you definitely should take your medication, that rescue medicine, to try to prevent the seizure from happening. And by the way, this is off-label use of the nasal sprays. But I do advise my patients to if they always have the same pattern that they're going to have a seizure with that same aura, like a big seizure, just I advise them to take the rescue medicine. The other thing is if the aura lasts for long enough, it can cause brain damage. So I will tell my patients, if it lasts over a minute or if it lasts for 2 minutes, it just kind of depends on the case. I'll tell them to take rescue medicines in that case. Other questions?
Would nasal, I don't know if I got that pronunciation correctly, but, would nasal also work as a preventative if you get that aura, or should you only use that for spray?
Yeah, so the question is, should you use the nasal sprays to help prevent seizures, or is it just for treatment afterwards?
Or when you feel the aura, you kind of feel it.
Yeah, so I think it depends on the case, but for some of my patients, I do recommend taking the medications at the onset of the aura to try to prevent it.
Yeah.
Exactly. Nothing's 100%, but I think it's worthwhile to try it. And then, if we tried it a few times and it didn't work, then can always change the directions. But I think it depends on the case, but I'll tell my patients you can try it.
One more question. I've heard of issues with epilepsy and altitude.
Yeah.
Concerned with the filter for oxygen, I heard something like you don't go above 6,000 feet. So I wanted to know how serious that is, how realistic that is, also what that implications are for flying that.
Oh, yeah, that's a good question.
Yeah.
Yeah, so the question was about concerns about going to altitude and having breakthrough seizures. And then the second part of the question is it safe to fly? Because the pressure is a little bit different when you're in a plane. So what we know about altitude and seizures is it oftentimes is that like getting used to the altitude can trigger seizures. So if you're used to living at, San Francisco Bay Area, we're at sea level, then you go up to the mountains. It does take a few days to fully get used to being at altitude. And when you're at altitude, less hungry, so you might not be drinking enough water, eating enough food. Also, it impacts your sleep because of the change in the little bit of change in the oxygen levels. So it's not, I don't think it's the altitude itself causing the seizures, it's the getting acclimated to the altitude that's causing the seizure. So what I tell my patients is they can try to, slowly acclimatize. So maybe, instead of going from like sea level to Lake Tahoe's like around levels around 6,000 feet, maybe try to go to 3,000 feet, stay there for a few nights, and then gradually work your way up. I also think that drinking water with electrolytes, that helps your body hold on to more water, so you're going to be a little bit less dehydrated. That can help, but I think the changes in the sleep is that's hard to get around without just slowly going up to altitude. And then, once you're in altitude, once you're acclimatized, I don't think that there's an increased seizure risk. It's just that getting used to the altitude. And then about flying, I haven't seen a problem with the pressure changes in the cabin. Do you have anything?
But when you're at, if you're 30,000 feet, your cabin is actually at 6,000.
Mm-hmm.
So but again, it's only a short period of time.
Yeah. So Dr. Laxer, for the people online, he's saying that the cabin's at 6,000 feet when you're flying, but usually you're flying just for a short period of time. So that shouldn't impact.
What about like a 10, 12-hour flight?
Yeah, 10, 12-hour flight. Yeah, that's
Actually, getting dehydrated probably is more important.
Yeah, the dehydration. Yeah. So again, I tell people I'm a big proponent for using those electrolyte solutions, help you stay hydrated. And then with taking 10, 12-hour flight, the other thing that you're running into is if you're flying for that long, you're gonna have a time change. So the jet lag can trigger seizures. Usually I'll tell my patients to, depending on what medicines they're on, but I'll tell them if they're taking a long haul flight like that, take extra dose of their medications. And then I do give people rescue nasal sprays when they're flying also, just in case. Yeah. Other questions?
Yeah, sorry to be greedy, guys, but I want to Ask the question.
Well, you've got the microphone.
Yeah. So I heard you say earlier that some focal medications might not work for people with generalized epilepsy. Is that correct?
Correct.
Yeah, it's so interesting to me because I've always imagined generalized seizures, even though if they're on both sides of the brain, to truly originate at one spot and spread, right? So it's surprising to me that it wouldn't work.
Yeah, I don't have a good explanation, but so the ones that we worry about worsening generalized epilepsy are Tegretol, trileptal, carbamazepine, oxcarbazepine. Those ones are the ones that are notorious for worsening generalized seizures. But with that being said, not every patient follows the textbook. I do have patients that have generalized epilepsy. I have a patient who's on Tegretol doing super well. So we just, they did not want to change, so we didn't change.
Thank you. Well, I was about to ask the question.
Back in,
I have a quick question. You mentioned the epidemics. So there's a lot of patients with epilepsy who smoke pot or pot gummies. And sometimes it's clearly that they really suffering their seizures, and many times I've seen them basically tell me that it's whether they like it or they're anxious, I look bad. So, whether or not it's a good idea for them to be doing pot, you caution them if they're on home feed that maybe it's not a great idea, or you might need to adjust their home feed if they're going to be smoking a lot of pot.
Yeah, it's a good question. So Dr. McMullen asked if someone is smoking pot, should we be worried about the on-feed levels? And I'm not aware of that interaction. So the dose for the Epidiolex, which is the CBD medicine, is a lot higher than you could possibly smoke or eat. So I haven't heard of pot making off-feed levels higher. The interesting thing, so about cannabis, so we know that CBD helps seizures. The flip side is THC can worsen seizures. So something to be aware of. We have in California, lots of people smoke or consume cannabis, and I just caution my patients, just try to steer clear of very high strain or very high THC strain cannabises. And then if you notice that there is a link between, like using pot and seizures, if you notice that that's a pattern for you, then just it's not worth it. You should just don't use the cannabis.
Any other questions? Shelf life for the rescue meds?
Oh, that's a good question. So the question was, what's the shelf life for the rescue meds? And it's 1 to 2 years. So that is something I tell my patients when they pick it up, make sure you look at the expiration date. And if it looks like it's going to expire soon, try to get the pharmacist to switch it out. But we think it's 1 to 2 years.
Other questions? You're gonna go right to left and then to Zoom.
Yeah, I noticed in one of your first slides, you had medication that increases the cover.
Brilliant.
Yes.
Mhm.
Can you expand on that?
So the question is asking for more information about Brubiact as a substitute for Keppra. So what I'll say is it's very, very similar to Keppra, but they tweaked it a little bit. So there's a receptor called the AMPA receptor that Keppra can hit. We know medicines that hit the AMPA receptor, those can cause mood issues. Another medicine that hits AMPA is Vicompa or Perampanel. Brubiact doesn't hit that receptor. So it's just a little bit more specific to other receptors in the brain. Brubiact is a twice-a-day medicine, and it does not have a long-acting version, right? Keppra does have a long-acting version, which I mentioned before. I love the long-acting versions in my patients, but Braviact is a twice-a-day medicine. But the side effects otherwise are very similar to Keppra, except it's supposed to be less irritability, depression, anxiety with it. Another thing to know about all of the medications I talked about, they're all still on brand. So that is something to be aware of is coverage might be different and the costs might be a little bit different. So that is something that we do consider when we're picking medicines. I don't want to prescribe a medicine that is going to be unaffordable. All of these pharmaceutical companies, they do have vouchers on their website. So if you do have a high copay for any of these medicines, you go on their website and virtually all of them have a patient savings section on their website, and you can get a coupon. And most people are qualifying for the coupon.
Nasalim's like over 1,000, isn't it?
Oh, yeah. So for people on Zoom, the copay for Nasalam, also Valtoco can be expensive, but the coverage is very good. So insurance companies, they know that these are good medications because it can help prevent you from going to the ER for seizures. So coverage is actually quite good for both Valtoco and Nasalam. But if you do have a high copay, I tell everyone this, go on the website, put in your information, and most people qualify for some kind of voucher. And the copay should be like $20,
All my washers.
$50 with that coupon, which is pretty affordable.
Yeah, and also, pharmaceutical work.
Oh yeah, they're here, so we can talk to them about those kinds of questions.
Next one.
For someone that does not have auras, is the nasal spray, would it ever be used either during a seizure or post?
Good question. So the question was, if you don't have an aura, can you use the nasal spray during a seizure, after a seizure? So they are meant to be used after a seizure to prevent another seizure from happening that same day. That's what the label is, so to prevent seizure cluster. I do tell my patients off-label, you could use it, someone could give it to you during a seizure if they felt like it was safe. So if you have a seizure that you're moving around too much, it's not safe to stick something in your nose and press a button. Don't just wait until after the seizure is finished.
And just to follow up,
Yeah.
is the nasal spray always prescribed by the epileptologist or neurologist? Does it have to be?
Oh, no, it doesn't. It can be prescribed by anyone.
Oh.
Yeah, so there's been some talk about having ER physicians or ICU physicians prescribe it after an episode of status epilepticus, which is a condition where seizures don't stop. So that it can be prescribed by anyone. But for it to get covered, it has to be prescribed for diagnosis of epilepsy. It won't go through, it's just for seizures.
Oh, yeah.
Popular.
Sorry, one more. So if someone has epileptic and non-epileptic seizures,
Mhm.
and this rescue,
Mhm.
is there any feelings on it?
Oh, yeah. So, yeah, there's, in my mind, there's not too much of a downside. It's just these medications can't be used too frequently or they'll quit working. So for Nasalam, it's not more than every 3 days. For Valtoco, it's not more than every 5 days. And that has to do with, these are in a class of medicines called benzodiazepines. And if you take them too frequently, then your brain gets a tolerance to them and they won't work for you. So this reminds me, I do want to talk a little bit about non-epileptic seizures and seizure diagnoses. So we have a 5-bed epilepsy monitoring unit at CPMC, and the gold standard for knowing if something is epileptic or non-epileptic is to get it captured on video EEG. So, someone came up to me, during one of the breaks asking about, a spell, and, the video can like show, and I just want to echo, it's so great. And like, I love it when patients bring me videos of their seizures. That can be helpful for the diagnostics, but the gold standard is to have the EEG on the head when it's happening. Oh, and, non-epileptic and epileptic seizures oftentimes can happen in the same patient. So we don't understand why, but, patients with epilepsy can be at a higher risk for the non-epileptic seizures too. So that's why it's also really important for us, someone having non-epileptic, for us to get the EEG evaluation, just to make sure that we're not also missing co-occurring epilepsy. Another question? 10:47. We're a little over.
So, is it like, during the seizure, is it safe or is it danger to like let the seizure stop or give the medication to stop the seizure? Is there advantage and disadvantage? If you stop the seizure, like, what it like, for example, after that, while doing the seizure?
Yeah.
just let it-
Yeah, it's a good question. So, with these nasal sprays, and when, giving pills, it's not going to get into the body right away. It takes about 4 minutes for the medication to come in. And a lot of seizures are going to be over before that time period. So I just recommend just give it as soon as you feel like it's safe to give it. Don't put the patient at risk trying to get the medicine in them.
Very good.
Did I answer your question? I see.
So just give the medication during, it's okay to.
It's okay to give it during, yeah, it's okay to give it during.
And we have some Zoom questions.
Okay.
Well, I'll make it really fast. What's the brain damage? What's the brain damage? What's the brain damage? When the seizure lasts so long. And I guess that's the question, was the difference between an aura and a seizure?
Yeah, so, let's talk about what an aura is. So an aura is, is a feeling that someone gets before what we call a full seizure happens. To make it complicated, we think auras are seizures. So a seizure is when there's abnormal electrical activity happening in the brain. An aura oftentimes, or is defined as the patient is, aware during it, so they actually are conscious feeling the symptoms. Common aura symptoms can be like a feeling of deja vu, or a feeling of like rising in your stomach, like you're going over a roller coaster, or tingling. Sometimes people feel like a hot flash, or like a sense, like a very like sense of like dread, or a bad smell in their nose, or bad taste. So these are common aura symptoms. So, auras can just happen on their own. And if it's happening on its own, then this is, a focal aware seizure, or the older term is, simple partial seizure. So that's what an aura is. But an aura can sometimes lead into a bigger seizure. So, and the bigger seizure is, when consciousness goes away. So if you like start to like black out. And the term for that is focal impaired awareness seizure, or complex partial seizure is the older term for that. To make things, they like to confuse people, and the terms for seizures change like every like 10, 20 years. So if you've had epilepsy for a long time, you're probably calling them complex partials or simple partials if you're newly diagnosed. You might be calling it focal aware seizure, focal impaired awareness seizures. Or yeah, grand mal, that's one of our oldest terms. They're all interchangeable. So, then the second part of the question is when does brain damage happen? So we think with auras that last for longer than 10 minutes, that's when we worry about the possibility of brain damage. So that's why I am a big proponent for giving people rescue medicines, because 10 minutes is a long time for your brain to be short circuiting and